We live in a busy, noisy, and pressure-laden world. Being able to deal with that environment is not easy. Coping with stress, anxiety, and depression tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. There are times when it seems that if it weren't for bad luck, we'd have no luck at all. It's more than a case of the blues and can push us into a psychologically dark space. First, let's take a look at this week's Prairie Doc quiz question. The best option of therapy for someone struggling with anxiety and panic disorder and even depression is to pick the best of these options. Number one, a regular exercise program. Number two, a regular dose of Ativan or other benzodiazepine. Three, touch and hand holding therapy. Four, improved sleep with a cooler bedroom and no TV. Pick the best answer among those options and give us a call. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We will announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answer in. We answer your questions about stress, anxiety, and depression as they are called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight is Dr. Robert Nuss with Avera Medical Group, University Psychiatry Associates, Sioux Falls. Welcome for joining us, Bob.
Thank you. Good to be here.
So now you have a MD degree. Tell me about where you trained and what happened.
I've got my medical degree from the University of South Dakota, and then I actually took a rather meandering path into psychiatry. I did a transitional year in medicine out in West Philadelphia, and then actually came back to Sioux Falls and did years 2 through 4 of my psychiatry residency.
Oh, wow. And what brought you here? Did you grow up in South Dakota?
You know, no, but my dad was a military guy, so...
You were everywhere.
We were everywhere, but the tether was always back to Tripp, South Dakota, so...
Tripp?
Yeah.
Yeah. Not far from the Air Force Base near Rapid City, or where is Tripp?
Tripp is south of Mitchell, so...
Oh, I'd forgotten.
Yeah.
So, well, welcome home. You've been here for how long?
Well, in Sioux Falls, I've been practicing with Avera for over 4 years now.
Great.
So it's been coming up on a decade, which...
Yeah. Wow. So let's talk about the issues of anxiety and stress. Let's start with stress. Stress is one of those things that many people have many answers for. What would you define stress as?
I think stress is our everyday life, right? So
who doesn't have it?
Right, exactly. We all move. We move through the day, and we engage people. And there are times when it's stressful, and there are times when it's less stressful or not stressful. I think the idea of the stress itself is it's something that we are participating in and able to tolerate and get through.
You know, I was told by a buddy of mine who said, I think stress is one of those things that keeps us moving forward. I mean, if we didn't have something bugging us, we wouldn't be on time, we wouldn't get our job done, we'd just sit back and we'd probably still be in a tiny little colony of Homo sapiens in northern Africa.
So you're saying I need to be more stressed.
But stress makes us move.
Yeah.
So so the result sometimes is anxiety, and I would say that clearly. Everybody has stress. Everybody has anxiety. how would you define anxiety, and when is it bad?
Well, anxiety is kind of the next step. So stress is, you know, working and walking through the day and kind of rolling with the punches, so to speak. Anxiety is when it kind of knocks you down. So, you know, by definition, anxiety is this overwhelming worry for most of the time that is impacting your ability to function daily, your quality of life.
So function is it, you know, it decreases.
Yeah. Yeah, the functional piece is really important, and that's, you know, outside of, if there's no dysfunction, then you may have some stress and worry and anxiety, but it's nothing to the point where we're concerned about things or feel we need to treat it medically.
So I often think about that family and that homestead, that farmhouse, sitting in there, kids are gone, farm is deteriorating a little bit, he's stressing out, she's stressing because he's stressing out. How much of that stress do we spread around our family and our friends?
It's a great question, and you know, the honest answer is probably a little bit unknown. You know, with epigenetics today, like there's more and more evidence out there that even stress in the womb is something that's passed on. So
oh, really?
Stressful pregnancy can lead to a stressful baby. We're all human things. Like if the person next to us is miserable, it's pretty hard to feel
happy.
Yeah.
Yeah. So I think that anxiety, I agree with you totally on that. I think the anxiety issue is something that we all deal with, but we could deal with it better one way or another. So how do people normally or usually or commonly or sometimes uncommonly respond to stress? I mean, what? Let's talk about the reason they come to the psychiatric hospital with stress. To explain that story.
Well, I mean, you know, when it gets bad enough, and again, it goes back to the ability to function. When things get so bad you're not able to function at all, I mean, that's where we start to see folks in the hospital. But we see folks beforehand too. I mean, we see them in clinic too, and you know, those situations, they're a little bit different in that, you know, things haven't gotten as acute. I think one of the biggest struggles with anxiety is that it's a very isolative disease.
Isolative meaning?
You're by yourself. No one wants to sit, you know, say, boy, I'm really worried about this silly thing that I shouldn't be worried about. You know, for a lot of men, it's embarrassing. For a lot of women, you know, people start to kind of have their thoughts if someone's worried all the time. I think that it being that type of disease makes it difficult to treat because, you know, we're all kind of pull ourselves up by the bootstraps types, right?
Well, that's South Dakota, isn't it?
Absolutely.
Yeah.
And the result sometimes is kind of this thing that gnaws and festers. And people don't come to seek help until they absolutely have to.
Some self-medicate. Explain that.
Well, I think, again, like we all try to figure it out, right?
Right.
So in anxious times, some of us we're avoidant. Say, no thanks, I'm stepping away from that. Other folks find drink or drugs or something else to kind of alter how their mind is feeling. There's certainly a lot of folks out there that will use or misuse alcohol because it does seem to help a little bit with that anxiety piece in the short term.
Right. Well, so let's say they come to you. You see that their stress, their anxiety is interfering with their life. So what are you going to do as a psychiatrist, as a primary care doctor? What is the right thing for that care provider to do to help somebody with the stress issues?
I think number one is to take a moment and listen. I think it takes a lot of guts to go see your family doc who you've known for years, or your psychiatrist or a psychiatrist that you don't really know, and kind of open up about the stuff that's really bugging you. So I think in those situations it's important for us to step back, be quiet, and listen.
Listen.
Yeah.
What is this thing about listening?
I know it's bizarre these days.
That's your best tool, isn't it? For
I think it goes a long way. You know, we live in a day and age where things are busy, and it seems that there's no time to listen, and I think it's what we need most.
I believe that. I think about a 95-year-old guy who would come in every 3 months. I'd listen.
Yeah.
You know, and I got done with a visit with him one day, and he's getting up to leave, and he says, I think I'd live forever if you continue to be my doctor and listen like you do.
Yeah.
How about that?
Well, unfortunately, it's a unique attribute in medicine today. And, you know, I think that we need to step back and think about how should we do this.
How are we practicing medicine?
Yeah.
We need to listen more. No question. You and I agree with that 100%.
Yeah, we're on the same page there.
The problem is convincing the rest of the doctors who have a timeline. They have a timeline.
Right, there's
and the
pressures,
computer.
Yeah. Oh, the computer. Yes, the computer exists.
Oh, the computer.
So, I mean, you know, beyond the listening piece, which I do feel is important, and I think that does help guide how we treat someone. You know, we've got medicines that do a nice job in treating anxiety.
So we do have good medicines to treat anxiety. What are the medicines that we usually use that we shouldn't use to treat anxiety?
Well, that is a very good question. So, I mean, there's the benzodiazepine class of medication. So, Ativan and Klonopin and Xanax. And those are, you know, people talk about happy pills. And they're very attractive because in the midst of being miserable and anxious, you can take a pill.
Feel great.
And it cuts it. But in the end, you're just masking the issue.
It's just a mask.
Yeah.
So what about post-traumatic stress syndrome? Now, that's a big issue in the veterans world, and we're going to have a roll-in a minute about it. What do you think, how big of a deal is that?
Well, you talk about a disease that impacts your daily life. You know, PTSD occurs. It doesn't occur necessarily because people experience traumatic events. There are a lot of folks that experience traumatic events and they do just fine.
Right.
It's the experiencing of traumatic events and not having any control over it.
Well, if you were the head of the Army and you had your whatever wish you wanted fulfilled, what could you do to prevent the PSD scenario?
You know, I think that's the challenge, is how do you prevent the thing that we can't really pinpoint. So, I mean, we can have twins who experience the same issue, and one ends up with PTSD, the other does okay with it.
And you don't know really why.
Yeah, and it's difficult. We know the reasons why, because there's trauma and there's the lack of control in that event.
Right.
But as for predicting who's going to have that, it's very difficult.
Very difficult. Yep. While military service often fosters resilience in individuals and families, many service members experience mental health challenges. In fact, 22 veterans die by suicide every day, but help is available.
When we have a veteran coming in here, it's usually after a deployment or some traumatic event. If they come in to see me about PTSD treatment, I will refer them usually to the VA Medical Center or to the Vet Center. The Vet Center was brought about from the Agent Orange settlement. The Vet Center does not release their records to anyone without the veteran's permission. The Vet Centers also do counseling for family members. And here in Brookings, we do have 3 counselors that I'm aware of that also deal with the veterans and PTSD. PTSD is not just limited to one age group or anything like that. And one of my best success stories actually was a gentleman that's already retired. He was in Korea, and he was a mechanic that they put into the morgue detail. And this affected him for a long time, and so after he had turned 63 or so, we finally got into some counseling. And it did not take all the problems away, but he was able to enjoy a better life after that. Also, we have ones that are Desert Storm veterans. Soon they did take the 30-day inpatient, and now they are working and a useful member of society. Because a lot of our veterans that have PTSD will self-medicate. And that means that they also have, basically a dual diagnosis. Either it's some kind of alcohol or drug dependency. So these programs are really good. It gives them that 30 days out away from any of the influences that they might have. And those can be extended up to 90 days in some cases. Right now, they'll go through, like you say, they'll do the counseling, they'll see a psychiatrist at the VA. They may refer them out to a counselor in the area or have them see the vet center part. Then also they do some medication management also. So if you're going through depression, just remember that you're not by yourself. Okay. The other part of it is everyone who's been in the service has went through certain things together. And so there's a certain amount of camaraderie that we do have. Everyone's done basic training. Everybody's been yelled at a number of times. And so that's something that you can come in and talk with a veteran service officer about, and we can help find the way to make it work better for you.
This is your program, and your questions are key to the direction of our discussion. Call in your questions to 1-888-376-6225 or send us an email to ask@prairiedoc.org. This is your show. Your questions really make this work. I have to say that Mikey Holzhauer, a real professional and a good friend, had a beer with me last night. it was good. He mentioned this happening tonight, so it was. Thank you, Mike, for helping us. But we've got some questions, Bob. Let's just jump right in. I have been feeling sad for a long time. Should I start with my primary doctor or seek out a psychiatrist? Good question.
That is a very good question. I think a good start is with your primary care doctor. The medicines that we use are safe medicines that are prescribed by primary care docs all the time. And then, the other option to this too is sometimes it's a little bit of therapy that goes a long way in beginning to address these issues and difficulties. So they can have some recommendations for that also.
As a primary care doc talking to a psychiatrist, I have to say that for many years I would start therapy, but I did a lot of listening, and when things got worse, then you got the brunt of the trouble. And so it was very important for me to listen carefully. And the medicines do work, and it's nice to see it happen, and it's nice for them to be able to do that at home.
Yeah.
A caller from DeSmet said, and go Bulldogs, says, my high school age daughter tells me a friend is talking about suicide. What should she do? That's a scary question.
That is, and that I think it seems to be an issue, and certainly national statistics have shown this. There is more and more suicidal thoughts and more active suicidal gestures in young adults, young kids, adolescents these days.
And I think in South Dakota we're right on the top of the list of states in the country with suicide, and the risks are very high right now.
I think in that situation, if someone is talking about that, it's important to let people know. So, if someone is making comments about wanting to kill themselves, then I think it's important to contact EMS, let them know, and they can go check things out. And they have the ability to go and ensure that things are safe. Sometimes we don't think about our friendly neighborhood policeman playing
as
that
a good
role.
guy.
Right, but they do a great job of reaching out to people when they're absolutely in that moment of need, and we should lean on them.
When somebody's talking suicide, it's time to start some action, and I think that sometimes just calling the counselor, the school counselor, if that child has a really good connection with X, Y, or Z, then you talk to X, Y, and Z. So that sounds like an important thing. I agree with him. Let's contact somebody. Don't just, oh, and they don't want anyone to know, so I can't tell anybody. And the answer is, you need to tell somebody.
Yeah, it's difficult because I think the younger generations now, they communicate differently. So there's a lot more social media driven conversations, and perhaps once upon a time when we'd sit down with a friend and vocalize these concerns, that becomes kind of an online event now, and just because it's online doesn't mean it's not important.
Wow.
And we have this tendency to want to try and say it's fine, and we can't predict it. Like, we have to be careful.
A woman from Brookings asks if you can touch on depression in the elderly, aging, differing social experiences. So depression in the elderly, it's a real deal.
It is a very real deal, and I think that the difficult part is that, and I've had lots of my patients say this, you don't know how I'm feeling because you haven't been there. And you're right, like I have not.
Yeah.
And if I'm blessed, perhaps I get there at some point.
To be an old person?
To be old and to have those struggles. But it is difficult to lose independence, both physically and mentally sometimes. And to see your friends move on, to sometimes see siblings and kids pass away. These are massive life changes that are difficult to work through.
And they happen to elderly people because the elderly are living past the other person's lives. I mean, it's just a reality. If you're going to stay alive, you're going to see your friends die, and it's a tough thing.
And I think it's difficult to discuss too, because our older population, they do have the stiff upper lip, and it's
they do, don't they?
You deal with it and you move forward, and grief and loss and depression, you push through it for a while, but at some point you just run out of gas.
I heard one statistic, I don't know if it's true or not, but that the highest risk for suicide is the elderly man whose wife just died.
Absolutely.
You've heard that same thing?
Absolutely, that is the case, yeah.
Depression is a real deal. Let's just talk a little bit about depression.
Well, I mean, depression is low mood, and that's pretty ambiguous, and we talk about impacts to sleep and interests and overwhelming feelings of guilt or low energy or poor concentration. You can see appetite changes. Some folks, they just look like they're walking through molasses.
Walking through molasses?
Yeah, they're just in slow motion.
That sounds like a good song to write.
Not bad. You don't want me to sing it, though.
No.
And then the suicidal thoughts too.
Yeah.
And that a combination of those symptoms for an extended period of time, I mean, it's kind of what we label as depression.
But don't you think that everybody has depression through their lives, off and on? It's just if it causes dysfunction, like you say,
Yeah.
it takes you away from being able to function. Then it's
Yeah,
a
I think
problem.
it's at that point where it's important to seek out some assistance.
There are people who have been trained in this, so consider that seeking out some help. A caller from Rapid City asked if there are genetic testing to help discern what kind of antidepressant will work best. There's all this about which drug will work.
I think that's a really great question, and I know that as science progresses, we have more scientific options, and certainly there are genetic tests out there that will measure how well your body can metabolize certain medications. And I think we should use that as a tool. If I'm treating someone and we've tried a couple medications and there have been poor response or no response or significant side effects, well then sure, let's use that tool and take a look at what's going on. Where I feel that it's misused is you've got someone who's stable and doing fine, you check the genetic testing, and the genetic testing says, well, that, that medicine is, isn't compatible. So then suddenly, you're changing medicines on someone who's doing fine, and oftentimes you just end up pulling the rug out.
You've seen that happen.
Yeah.
Wow. Well, that's an important lesson, I think. We have a caller from Sioux Falls who asks about the risk of having guns in the house and the potential for suicide.
Well, I think it's important for all of us to recognize that suicide is oftentimes an impulsive decision. So,
particularly when they're younger.
Especially when you're younger, or in situations where there's some intoxication, or your brain is not working the way it normally does. So the challenge and the danger of having guns around is that if there's that impulse, there's that option too. And as it turns out, guns are very deadly.
Take away those options when the person is at risk, no question.
And I think it's important because we do live in South Dakota, and hunting is part of what we do.
I got guns in my house, and it's just
So I think you gotta move those out when there's moments of concern and danger, but it doesn't mean that they're out forever.
Right.
If you're doing better, then part of our hobby, is part of what we do, is to get back into that.
Part of my joy is to hunt pheasants. And I can't think of a happier moment than bringing up the memory of walking through a cornfield with my dad, and I had a pop gun. He took me on hunts, but I didn't have a gun. So those are, I'm a hunter, and I love venison, and deer is fun to shoot. So I've done enough of that too, but I have to say that we need to be careful about those guns when the time is right in particular. Maybe we don't know the time is right, and we just have to take those guns and make them safe.
I think better safe than sorry.
A woman from Sioux Falls asks, does anxiety or depression elevate blood sugar for diabetes?
It can, yes.
Really?
Yeah. So it's a stress response. Some studies out there recently too that are kind of indicating that even depression, anxiety issues, untreated, increase risk of blood clot and strokes. It makes your platelets stickier.
It really goes down to the wellness triad that I always say. Exercise is the bottom line. You got to have exercise. It's so important. Second component is maybe eating less. You don't gorge yourself, and just eat less calories. A balanced diet and lots of fruits and vegetables and all that, but eat less. And the third one is connection with friends. The spiritual relationships that you have with other people, I think those are very important. And it's interesting that diabetes is part of it. Maybe it's because you're not exercising because you stopped because you were depressed and you're just sitting there.
Well, certainly it seems that our current diet sets folks up to have metabolic problems.
Right.
And, again, there's a lot of new studies out there showing that if your mood is good, you take care of yourself, which seems to be pretty common sense.
Yeah.
But it is something that is being talked about more, that managing mood and controlling anxiety means that our blood pressure is better, and we take care of our sugars the way we ought to, and we go get the exercise we're supposed to get.
Yes. A caller from Wagner states, you what? Still. A caller from Wagner states, my sister died from suicide. She had a long history of depression. I heard that if one child in a family dies by suicide, there's an increased risk of another child dying in the same manner. Is this accurate? I have depression too.
First of all, I'm sorry to hear about your
too.
sister. That's a tough situation, and that is a traumatic situation. There are some certainly reports out there that indicate that these traumatic issues kind of lead to more potential for traumatic issue.
Yes.
Which, to a certain extent makes sense, because You know, it's those shocks and those challenges that we're not able to work through that tend to stick. There is certainly a genetic component to depression and anxiety also. You know, I think, you know, when we're looking at those types of statistics, to recognize that, you know, they're going to lean more that direction because there is that increased genetic risk too.
So we need to have attention to that issue.
Yeah. And I think talk about it.
Yeah. Well, we're on a campus here where we have a lot of kids. Kids meaning 18 to 22 and plus. And this is in a world where there's a lot of elder depression like we talked about, probably more in the elderly. What about young people with depression?
Well, it's there. So, I mean, depression is a disease just like diabetes is. So there are folks.
Oh, are you saying there's no judgment against people who have depression?
Oh, yeah, no one judges, right?
Yeah.
I mean, that's one of the difficulties. It's a very lonely disease because it's hard to feel crummy and go do things. And it's hard to feel crummy and want to talk to people about it. It's hard to choose to be vulnerable when you're not sure how someone's going to react to you. And there certainly are preconceived thoughts and worries that probably are reasonable concerns that drive kind of this negative response to getting treatment. For kids in college, I mean, there's so much change. You're off on your own. There are all sorts of pressures going on. The responsibilities that you're responsible for now. Classes that are more challenging.
Yeah.
So there's lots of risk.
Huge transition time in your life. Oh my gosh. Yeah.
And I mean, classically, that's where you hear stories too of, you know, first break bipolar disorder kicking in, and even schizophrenia. It's during those stressful moments where things will kick off.
Trying to get through the college years. You know, it's a great time for many. It's a hard time for many.
Yeah. Well, and I think that is the pressure too, because it's supposed to be the best time of your life.
Yeah.
And it doesn't feel that great if you're not feeling like it's the best time of your life.
Yeah. Mental health issues such as anxiety are becoming more prevalent in the college setting, which is why it's important for students and concerned family members to be familiar with it.
We do have a large amount of students that need or want or use our services. A lot of anxiety and depression related diagnosis, because mental health problems that are more chronic generally start presenting at the age of the college student, partly because at that transition in life there's a lot more stress and pressures and a lot of decisions and big changes that go on. And then there's also the development of the brain and the body. We have a lot that'll come in and they're more acute. Like I said, they don't need many sessions, maybe they need 3 or 4 to kind of adjust and develop healthy coping skills and resources. We can provide individual counseling sessions. Our level of care is usually weekly or less as far as individual sessions go. We do offer 3 different kinds of groups each week at this point. This semester we're offering a grief group, an ecotherapy group, and what we call a Wise Minds group, which works on emotional regulation and relational issues. We also have urgent care where if there's a crisis during the day, they can come into the clinic and be seen within a timely manner, and we have 24/7 on-call on campus. The trend right now as far as suicidal ideation, thoughts of death, or even self-harming behaviors is increased a lot. Primarily the coping skills and how I think social media and stuff influence that element. Thoughts of suicide are a symptom of something going on. They're not the only thing that person has going on. We do, our on-call services help with the acute crisis situations that may happen. We work with the Brookings ER system a lot if a person's brought there. UPD is also uses us for welfare checks if needed. I would suggest the earlier the better, so that way it's more a few sessions and maybe you see progress, you understand yourself a little bit more, and you understand how to manage that a little bit better. Whereas if you wait too long, you chance creating more of a pattern and deeper symptoms that take longer to see decrease in.
This is such an important topic. I mean, I don't know how exciting it is, but to me, this is like the bottom of the pyramid that is important in the quality of life for people. How would you respond to that comment?
You know, while some refuse to believe it, there's a fair amount of common sense in psychiatry. And it's pretty easy to say, boy, I mean, people aren't doing well, they're anxious, depressed, therefore they're not doing well because they're anxious and depressed.
Yeah.
The challenge, again, is that it can be a very lonely path, and
Well, that just
that
strikes
first
me.
step is important.
That first step. You know, I'm just blasted out of this room with the idea that you said depression is such a lonely condition. And it is, you're right. I mean, I think about that, and I had never put it in that realm. People, there are a lot of lonely people in this world. And, you know, part of the treatment might be just to be a friend. An emailer has a comment, I just wanted to say that military people are not the only ones who have PTSD.
Absolutely.
So give
Absolutely.
me other examples you've seen that you can share without destroying privacy.
I was actually reading a book on PTSD, and the author was describing a situation where he was putting an air conditioner up in a high-rise building, and it slipped out of his hands. And you know, he watched this thing fall to the sidewalk, and all these horrible thoughts of people getting squashed and killed, and you know, he said that he struggled a lot with kind of those type issues for a while there, because it was a risky, traumatic event that he had no control over.
It didn't land on anybody.
It
though.
did not. No, everyone was okay.
That made me. But you think about the potential of hurting somebody. I have had the same exact repercussions, but it only lasted a couple, 3, 4, 5. Well, it's still alive in my brain. I'm driving up from the studio here to get back on 6th Street to go back to the clinic, and I come up to the stop, and I'm waiting for the cars on the left, you know, I'm ready to go across and then left, and he's stopped, and there's nobody coming. And I'm looking at the guy, and I look around, there's nobody coming, and he won't turn, and I'm thinking, I can go right now. I'm just about to go, and a bicycler drives right in front of, across from. Oh man, you think about that, and you know of accidents that were very similar to that. Breaks your heart to think about what you could have done, which makes you drive a little more careful, I guess. That's it.
You know, I don't think we mentioned it earlier, but what does PTSD mean?
Yeah.
So I mean, PTSD is post-traumatic stress disorder.
Right.
So, you know, when the caller had kind of said that, you know, you don't have to be in the military. Absolutely right. It's a post-trauma stress disorder.
Somebody would say raised in a mean family.
Oh, I mean, unfortunately, a lot of those abuses that occur leave scars.
Yeah.
And PTSD can be one of the struggles that people have.
Yeah. Yeah. What about I had another case of a person who attempted suicide, was hospitalized at the psychiatry hospital in Sioux Falls, and then after the suicide event, 3 days later, was released. You know, that's been a dilemma for me too. How long do you keep these people? What can you do to help them? And how do you know for sure they're not going to commit suicide after this?
Well, you don't know for sure. And I, you know, that story is one that you hear. Is, you know, there's this issue that happens that is dangerous and life-threatening, and you end up in the psych hospital for it. And in 3 days you can get some treatment, and certainly we can move through the acuity of the moment.
Yeah.
But I'm not sure if 3 days solves the underlying problem.
No.
And that's where kind of these plans for discharge are important.
Yes.
I think it's important also to recognize that you know, when you go to psychiatry hospital, some people go there involuntarily. They're sick, and you go in there on a mental health hold, and you're there against your will, unfortunately. You know, those holds get dropped. And then it goes back to whomever's in the hospital. If they want to stay, they have the option to do so. If they have no interest, they can say no thank you.
See you, bye.
Yeah.
You can't hospitalize them all. There was a question about bad bosses. I know full well when I have a good boss and I'm working for that good boss, I'll fall over a sword to satisfy that guy or gal that is directing me. And I have loyalty to them. But there are times when I see that bad bosses can destroy a person. They can pick out somebody they don't like, and then they can just drive them right into the ground.
Yeah.
What do you say about that?
I think it goes with all the relations that we have. You know, our engagement with other people dictates how we feel about ourselves, how we feel about them. It's tough to go to work every day for someone that you don't like, that you don't have respect for, because they don't have respect for you. I think, you know, those bosses who choose to be vulnerable, who choose to stop and listen, you're absolutely right. You get someone. Oh yeah, you get someone working for you who wants to work for you, not because of what you do or what you're paid, but because it's a good place to work.
Yeah, boy, that's so important. How could we teach that to every boss out there? An emailer states, "I have been," and we're running out of time, so we got to have short answers.
Okay.
States, "I've been suffering from severe anxiety, PTSD, and MDD," which is
Major depressive disorder.
"for almost 3 years now. Have tried multiple medicines with horrible side effects, been hospitalized numerous times. I feel like all my psychiatrist does is push different medications on me constantly, doesn't fully listen to my concerns. Can I get through this with just therapy and no medication? Should I try to find a new psychiatrist?"
I think those are all very good questions. I would say that if the depression has been that deep, that there probably is a role for medicines. The challenge, and my approach when I'm doing medicines, is my goal is to get you feeling back to yourself.
Find that right medicine.
Right. So, you know, it's important to you if the relationship you have with your psychiatrist is not working.
Find another psychiatrist.
I think it makes sense to go find an answer somewhere else.
Me too.
Yeah.
If you can love and trust your primary care guy or gal, that person will help you through so much.
I think that's where the role of getting into therapy is important too, because there's that listening component involved.
2 minutes, 4 question. A man from Sioux Falls states, "With depression, you often find a problem with sleep disturbances." We could go all night long on that one. So, do you find a similar problem with depression in people who are sleep deprived? Does sleep deprivation and depression correlate? Sleep disorders certainly do.
Yeah, the answer is yes, but it's a chicken or egg question. Like, you know, are you sleeping crummy because you're depressed and worried, or is it vice versa?
Yeah, don't know the answer, but the worst treatment would be what?
Drinking a bunch of coffee and keeping the TV on.
No, the opposite.
No, I mean the worst treatment is, again, like, and it goes back to those medications that are dangerous and addictive. You know?
Like Ambien.
Right, Ambien.
Bad choice.
The benzodiazepines. Again, you're just kind of you're putting someone down or trying to mask the issue as opposed to finding the solution.
We've got 1 minute. A man from us. Should we consider the love animals give to people as a means of treatment? You like, yes or no? Do you like animals as a treatment?
Animals, yeah. I mean, I think it's important, and it's accountability investment. Sometimes having a dog that you take care of gets you up and out of the house, and you've got something to focus your love on.
I agree. Caller from Aberdeen says her teenage daughter is showing some repetitive behavior, seems to be getting more frequent, starting to disrupt her life. OCD?
There's the potential for it. I think it'd be important to get in and get that evaluated.
Last question. A caller from Aberdeen says her teenage daughter is showing some, 22-year-old person can't function, sleeps 12 to 14 hours, no ambition to get a job, to do well in school, behavioral health won't accept her for hospitalization. What do you do?
I think that situation, I think it's establishing a good relationship with a psychiatrist and a good relationship with a psychologist.
All right.
Getting that therapy going.
Okay. And now for the winner of tonight's Prairie Doc quiz question. The best option of therapy for someone struggling with anxiety or panic disorder or underlying depression is pick the best answer. Number one, a regular exercise program. 2, a regular dose of Ativan or other benzodiazepine that we've already. 3, touch and handhold therapy. 4, improved sleep with a cooler bedroom and no TV in the bedroom. What's your answer?
Number 1.
Number 1, exercise. And the answer is number 1, our old friend, exercise improves almost every condition we can experience. It was Amy Chimanic from Trenton, South Dakota, who answered the question correctly. Thank you, Amy, for participating. A book will be in the mail to you soon. Our Prairie Doc production team has been planning for the future for some time now, and no matter how my present health concerns resolve, we know that laying the groundwork for the years to come is important, and we're doing that. We feel privileged to have had the honor of creating a legacy of service through the Prairie Doc organization.
It has been our desire and goal to share health information that is not influenced by marketing or sales, but rather is based on science.
We started in the 80s with a newspaper article and expanded in the 90s with a radio show. In 2003, we started a TV program, and in 2010, we added our social media platforms.
This has been a team effort made possible by many volunteer physicians and experts serving as hosts and guests. All of them are Prairie Docs.
Thanks to them, we've been given the ability to pass the torch so that this legacy may continue beyond my time on this earth.
Please join me in embracing our team of Prairie Doc physicians, each committed to this mission. Family physician Andrew Ellsworth, Deb Johnston, and Jill Cruz, along with internist Kelly Evans, all from Brookings, South Dakota.
These volunteer physicians, and many others, have in the past and will in the future serve as authors of Prairie Doc newspaper columns, host of our TV and radio programs. Thank you. Standing in front of a group of DSMET Parent-Teacher Association or PTA members, I was to play a trumpet solo. My teacher thought I was prepared, but unfortunately was not. My fears brought my heart up into my throat. I became short of breath. My heart pounded, and indeed I stumbled and had to start over again. Although my failings were likely amusing to some of the audience, they were certainly not indicating any musical skills. It was a devastating experience for me. During our lifetimes, all of us experience physical and psychological ailments. People will admit to physical trouble, but they don't like to admit to psychological problems. And most of us are reluctant to ask for help. Many of these feelings increase adrenaline levels, which in turn cause the fast heart rate, shaking, shortness of breath, dizziness, diarrhea, urinary frequency, sleeplessness, headache, sweating, generalized discomfort. Sometimes these feelings of anxiety are normal, and sometimes not. A reasonable level of anxiety can keep us driven to hunt for food, fix something, discover another frontier, and improve what we can improve. Without stressors and the anxiety that follows, some experts believe we would become lazy, stop dealing with troubles, and civilization would end. On the other hand, when feelings of anxiety expand out of proportion to the trouble that we are facing or come on easily and frequently, anxiety can sometimes interfere with normal functioning life. Too much anxiety can be harmful to the individual. We are all thrown off balance by one kind of psychological challenge or another as we struggle through the normal encounters of daily living. Who hasn't experienced periods of anxious moodiness that follow the reduced sunlight of winter, or anxiety following the loss of a job, or facing the demands of a new job? How does anyone handle a severe illness in a child or a spouse? Who can deal with divorce without anger, disappointment, and, you guessed it, anxiety? Life is often very difficult. Every individual will confront stressors in different ways, and sometimes we just need help. Bottom line, each of us must deal with our own physical and mental illnesses throughout our lifetime. Sometimes minor, like forgetting a trumpet solo. Sometimes major, like prolonged sense of anguish after the death in a family. When our ability to live a normal life is being interrupted by anxiety, then it's time to see the doctor. A big thank you to Dr. Robert Nuss for volunteering to come to our studio in Yeager Hall on the campus of South Dakota State University and add his experience and knowledge to our discussion tonight. If you'd like more information about this program or to see more episodes, please like and follow us on Facebook or visit us at prairiedoc.org. The number of confirmed cases of the flu has recently taken off. There are more people with the flu than at any time in the last 5 years. So far this flu season, over 280 people have been hospitalized, and there have been at least 7 deaths from complications, including last week, a South Dakota 4th grader. It's not too late to get your flu shot. It is important, not just for you, but to protect those around you. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
First doctors in the Americas used the tools at hand, plants, animals, and their insightful skills. With the coming of the Europeans, this natural and effective approach was repressed. Changes in Native American healthcare. Next time, On Call with the Prairie Doc.
For more than a decade, Dr. Holm, in his role as the Prairie Doc, has emerged as a leader of healthcare education and communication in South Dakota and across the country. Every week, Dr. Holm and other medical professionals volunteer many hours to share science-based truth about healthcare on public television, on the radio, in our newspapers, and online. And best of all, everyone has free, easy access to the entire Prairie Doc library. Hi, I'm Jennifer May of Rapid City. As a board member of the Healing Words Foundation, I ask you to consider making a donation. Please help us continue this important work. Go to prairiedoc.org and make a donation today. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information.
And with the ongoing support of these individuals and institutions.
South Dakota Foundation for Medical Care,
Brookings Health System,
Ophthalmology Limited,
Avera Heart Hospital,
Dakota Allergy and Asthma,
Fishback Financial Corporation,
Vance Thompson Vision,
Urology Specialists,
Brown Clinic,
American Academy of Family Physicians Foundation, and South Dakota Academy of Family Physicians.
Black Hills Medical Society.
Aberdeen District Medical Society.
Flandreau Madison Brookings District Medical Society.
Sioux Falls District Medical Society.
Yankton District Medical Society.
Dakota Bank.
Orthopedic Institute.
Physicians Care Sanford Clinic Community Service Committee.
Aberdeen Asthma and Allergy.
And Swiftel Communications.